Hi, this is Nursinga. Today we're going to discuss genitourinary disorders in the pediatric populations. First, some vocabulary terms. Dysuria means difficulty or discomfort with urination. Frequency and urgency are terms that are used frequently, meaning either an abnormal number of voidings in a short period of time or having to go very often, and then an urgency to void, but an inability to do so, or just dribbling or small amounts of urine. Nocturia is when you awaken during the night to void, and enuresis is when you lose control of your bladder, oftentimes during the night with voiding, and this is after bladder control has been established. Polyuria is when there's increased urine output, and oliguria is decreased urine output, not to be confused with anuria when there's no urine output. The urinary system consists of two kidneys, two ureters, the urinary bladder, and the urethra. By about the third month of gestation, the fetal kidney begins to secrete urine and replenish the amniotic fluid. The function of the urinary system is to rid the body of waste products and maintain body fluid homeostasis. The kidneys produce a substance, erythrocyte stimulating factor, that stimulates red blood cell formation in the bone marrow, and renin, which activates the RAS system and regulates blood pressure, and to an extent urine output. A decrease in amniotic fluid, or oligohydramnios, may indicate congenital renal defects. Since the kidney and urinary tract develop at the same time as the ears, there's an unexplained relationship between low-set ears in the newborn and urinary tract anomalies. An imaginary line should be drawn between the outer canthus of the eye and should be even with the upper tip of the ear pinna. If the upper tip of the earlobe falls below this line, the assessment should be recorded and reported because there's also the possibility of the urinary tract anomaly. And in these pictures you can see two kids with low-set ears. There are some differences for children with the urinary system. Fluids play a larger portion of their total body weight, so infants are more prone to fluid volume overload and fluid volume deficit. Until about age 2, they have immature kidney function and lower glomerular filtration rate. Although the newborn kidneys is immature, they do function effectively. However, they are at higher risk for medication toxicities, and because there's not a lot of fat padding around the kidneys, they're also at greater risk of kidney injuries if there's trauma. Most newborns urinate within the first 24 hours of life, and it's really important to record and report the presence or the absence of urination within those first 24 hours. If there is no urine output, it may be indicative of a urinary anomaly. Urine output varies by weight and age. And looking at these numbers, it may seem overwhelming at first, but it's important to recognize that regardless of age, the average urine output is roughly 30 milliliters an hour. For example, in the infants and toddler range, a 1-year-old weighs about 10 kilos, so they'd be 20 to 30 milliliters an hour. In the preschooler and young school age range, a 5-year-old weighs about 20 kilos, so they'd be 20 to 40 milliliters an hour. And in the school-age children and adolescents, the weight ranges from 40 to 80 kilos, which would put you at about 20 to 40 milliliters per hour. So for all of these, the average is still about 30 milliliters per hour. The bladder capacity of a child can be approximated by age in years plus 2 equals the number of ounces that a bladder volume could hold. So it's roughly 50 milliliters at birth and about 700 milliliters in adulthood. Why is that important? Only because the well-hydrated infant should urinate about every 2 hours. So if you think about it, they should be making roughly 20 to 30 milliliters of urine an hour, and they can hold about 50 milliliters in their bladder. A good sign of hydration then would be adequate urine output or voiding at least every 2 to 3 hours. The genitals in preterm females may appear swollen, so the labia minora may protrude past the labia majora. In boys, the testicles may appear large at birth and kind of in proportion to the size of the infant may seem very large. The testicles may fail to move into the scrotum, causing a condition called undescended testes or cryptorchidism, and we'll talk about that. The foreskin may be tight at birth, causing phimosis, and we'll talk about that as well. The sex organs do not mature until the onset of puberty, and secondary sex characteristics occur with the onset of puberty, although gender is genetically determined at the time of fertilization. The presence of a Y chromosome is essential for the development of the testes and their hormones. Sex differentiation occurs early in the embryo. The organs specific to the female or male child develop before the embryo has neither male or female characteristics, and ovaries occur later than the testes. By the 12th week, the external genitalia of the fetus are recognizably male or female, although typically we don't do gender ultrasounds until about week 20. The other kind of thing that we should talk about are behaviors suggestive of sexual abuse. So remember as a nurse that you're a mandated reporter, so you should know the rules in your state related to reporting and be able to recognize some of the behaviors that would indicate sexual abuse in a child. Now, any one of these alone would not necessarily indicate sexual abuse, but as a pattern or as you start to see groups of these things, it would raise some red flags. So frequent urination, excessive masturbation, encoparesis, which is fecal soiling beyond 4 years of age, severe nightmares, enuresis or bedwetting after potty training has occurred, irritation or pain in the genital area, a decrease in physical or emotional development, and suggestive posturing by young children or explicit knowledge of sex acts shown by children under 8 years of age who really shouldn't have exposure or knowledge of those things would require further investigation. Let's review some structural, infectious, and inflammatory anomalies of the urinary tract. First, let's talk about some male conditions. Phimosis is a narrowing of the preputial opening of the foreskin, which prevents the foreskin from being retracted over the penis. Now, this is normal to a degree in boys up to about 6 months of age. And if it's incredibly tight or is leading to problems with urination or hygiene or infection, it can be corrected by circumcision. Forcible retraction of the tight foreskin is avoided because it can lead to paraphimosis, as you can see here on the right. And essentially, drawing back on the foreskin over the glands of the penis can lead to almost like a tourniqueting type of injury where then the foreskin cannot be returned back over the glands of the penis, and it ends up causing like a massive swelling and tissue injury, and impairs the circulation and is a surgical emergency. Epispadias and hypospadias are problems with the location of the urethra. With epispadias, the urinary meatus is on the upper surface of the penis. With hypospadias, this is a congenital defect in which the urinary meatus is located on the lower position of the shaft. And it can be accompanied by chordee, which is where there's also like a stricture of tissue on the lower portion of the penis that causes like this downward and sideways curvature. In mild cases, surgery is not indicated, and that's usually if the opening of the hypospadias is very distal and out towards the tip, but surgery is usually performed on more proximal or mid openings, and especially if it's causing infection or dribbling, and we try to close it before 18 months of age. Routine circumcision is avoided then in these children, especially with hypospadias, because the foreskin may be useful in the repair. On the left, letter A shows kind of a mid-shaft dorsal opening of an epispadias, and letter B shows a mid-shaft ventral opening of a hypospadias, just to give you an idea of kind of a mid, kind of more proximal opening. And then on the right side here, there's a picture of a hypospadias, kind of all of the options. So it can be very distal, like the glandular one, all the way down to the scrotum or even the perineum, and they can be larger openings. Like you could have one that spans the entire section here from kind of pen scrotal all the way down to perineal. So you could have one that has like just a really large defect in kind of like that area. So the more proximal they are to the body, the more essential it is that they get repaired. So again, these kids just wouldn't have routine circumcision, so that we could use that tissue for closure. Exstrophy of the bladder is when the lower portion of the abdominal wall and the anterior wall of the bladder are missing. This is usually noticed by fetal sonogram during routine prenatal care. At delivery, the bladder is open and exposed on the abdomen, and urine just leaks continually from the bladder, and the skin can become excoriated. The bladder is kind of lightly covered to protect mucosa, but like you can't put a big dressing in place because it would obstruct urine outflow, and diapers are placed under rather than on the infant to protect the bladder while allowing urinary drainage. The baby should be positioned on their back or on their side so the urine can drain freely, and meticulous skin care is super important. Ideally, surgical closure is performed within 48 hours of birth. And just to give you an idea, you can have exstrophy of the bladder, or you can have what's called cloacal exstrophy, which includes the intestines and the bladder, and some of these are much larger and some are smaller. Obstructive uropathy occurs when kidney stones, tumors, strictures, or scarring causes a partial or complete blockage. This leads to fluid backing up into the renal pelvis, which causes the kidney to become enlarged and distended, and this is known as hydronephrosis. This swelling can cause permanent damage to the kidney. Polycystic kidney disease, seen here, is when there are large fluid-filled cysts that form in place of healthy kidney tissue in the fetus. This is caused by an inherited autosomal recessive trait. Kidney damage can result in an inability of the kidneys to concentrate urine, which results in metabolic acidosis, and stasis of urine, which increases the risk of infection. Remember that the kidney is responsible for making bicarb, which buffers the blood when we have excess acid. Patients with obstructive uropathy may require urinary diversion surgery. Options are ureterostomy, ilear or colon conduits, nephrostomy, suprapubic tube placement, and vesicostomy. And what the surgeon chooses depends on where the obstruction is. A nephrostomy tube, as shown in this picture, is inserted through the back or flank directly into the kidney, bypassing the ureter, bladder, and urethra on that side. It drains into an ostomy bag, and it's critical that the bag remains below the level of insertion to prevent reflux or backflow of urine into the kidney, and that the bag be attached to the child and not the bed, as it can get pulled out if they roll over. Some things to consider about children who have urinary diversion surgeries. The toddler may be unable to attain independence during toilet training. School-age children may suffer from feeling different than their peers and have distorted body image, and adolescents may have lowered self-esteem because they're concerned about sexuality. Urinary tract infections impact both male and female children. In males, it's primarily uncircumcised males until about the age of 6 months. These nosocomial infections impact uncircumcised boys primarily because the prepuce or foreskin cannot be easily retracted and the penis can't be cleaned until about 6 months of age. Girls have a higher risk of infections and recurrent infections due to a short urethra and the close proximity of the urinary meatus with the rectum. Escherichia coli is the most common pathogen in all pediatric UTIs, and it is a result of fecal contamination. Children under the age of 1 are often admitted for antibiotic therapy for infection, while older children can usually be managed with oral medication at home. Families must be educated on the importance of avoiding rayon or tight-fitting underpants or clothing, the use of bubble baths, or the use of holding the urine. Proper perineal care, like wiping front to back, hydration, and the avoidance of risk factors will help decrease the incidence of UTIs. Frequent vaginitis and frequent UTIs become a warning sign of sexual abuse and should be investigated further. As a nurse, you'll spend a great deal of time reviewing charts and lab results. it's important to understand normal versus abnormal. Not that just that the numbers are out of range, but the significance of the values when they are abnormal. In the urine, the kidney is responsible for the creation of the balance of fluids and particles. When the glomerulus or nephron are damaged, particles like blood cells and proteins leak out. We see glucose in the urine when the serum glucose levels are excessively high, and ketones when the body is dehydrated or in acidosis. Let's talk about the difference between nephrotic syndrome and glomerulonephritis. Nephrotic syndrome includes a number of different types of kidney conditions that are distinguished by the presence of marked amounts of protein in the urine, edema, and hypoalbuminemia. The edema typically starts in the eyes and around the ankles, and then spreads to become full body with ascites. Because of the loss of albumin in the urine, the patient develops hypoalbuminemia and further third spacing and edema. The blood pressure is normally normal in nephrotic syndrome. Onset usually follows a viral infection, and the patient may become neutropenic or have a low white blood cell count, so the risk of infection of other types like bacterial infection now becomes very high. This is seen most often in boys, aged 2 to 7 years, and may be related to a thymus T-cell dysfunction. For patients who respond to steroids, the prognosis is really good. Some common signs and symptoms include pallor, listlessness, irritability, and poor appetite. Diuretics are not effective in nephrotic syndrome. Steroids, however, will reduce the protein leaking from the kidney as well as edema. Our goals include preventing medication toxicity and preventing infection. Avoid adding salt to foods whenever edema is present. Fluids generally don't have to be restricted except if the patient has massive edema present to avoid further damage to the skin. Daily weights and strict I&O are important, as well as supporting care to the patients and the child. And parents should be instructed to keep a daily record of the child's weight, urinary protein levels, they can dip that at home, and medications if they're caring for the child at home. No vaccinations or immunizations should be administered while the disease is active or during immunosuppressive therapy. Frequent repositioning is important to maintain healthy skin. Glomerulonephritis, on the other hand, is an inflammatory disease of the glomerulus caused by an antigen-antibody complex that typically occurs about 1 to 3 weeks post-streptococcal infection. Parents usually note that the child has periorbital edema when waking and smoky brown or bloody colored urine. The urine output is often decreased, they have oliguria, with high concentrations of albumin, red blood cells, and white blood cells present. Since the glomerulus is damaged, potassium balance is impaired, and hyperkalemia with cardiac arrhythmias might develop. Hypertension and fluid volume overload are common as well. The child should be encouraged to rest until symptoms subside. Sodium and fluids are both restricted to decrease further edema. Potassium-rich foods and fluids are also restricted until the kidneys are functioning normally. Care is focused on preventing infection, managing fatigue, weights, and monitoring I&O and vital signs. Both diuretics and steroids are effective for managing glomerulonephritis. Wilms tumor is an embryonal adenosarcoma that is thought to have a genetic basis. Usually it's discovered before 3 years of age. It's one of the most common malignancies of early life, and there's no symptoms during the early stages. The abdominal mass itself is usually found by either a parent or during a routine health checkup. And on this scan, you can see how large that tumor is. And here you can see how large it looks from the outside. We refer to Wilms tumor also as nephroblastoma. It's more common in African American children and more frequent in males. IV pyelogram reveals a tumor that compresses the kidney tissue. It's usually encapsulated, meaning that there's kind of a capsule around it, and care needs to be taken not to break the capsule to prevent the spread of the cancer. Once diagnosed, abdominal palpation must not be performed, and the tumor is not biopsied prior to removal to avoid trauma to the capsule. A sign above the bed and a notation in the chart must clearly state no abdominal palpation. Care is the same as other children with surgery and cancer. Treatment includes a combination of surgery, radiation, and chemotherapy. The affected kidney and tumor are removed as soon as possible after diagnosis is confirmed. Preoperatively, again, there's no biopsy, and the tumor is not palpated. We start teaching about chemotherapy and radiation as soon as possible, and we do the appropriate preoperative teaching. Postoperatively, there'll be an incision, so abdominal surgery care is important, as well as management of airway, breathing, and circulation, prevention of infection, and careful monitoring of vital signs, intake and output, and pulmonary hygiene. We're very concerned about infection as well as the development of pneumonia. It's important to avoid contact sports to prevent injury to the remaining kidney, and that's a lifelong restriction. And teach the parents about prompt reporting of any genitourinary issues like fever, foul urine, flank pain, anything else. HYDROCELE is when there's an excessive amount of fluid in the sac that surrounds the testicle, and it causes the scrotum to swell, as seen here. A chronic HYDROCELE is one that persists beyond 1 year, and typically somewhere between 12 and 18 months, they start discussing surgery. These usually close and resolve on their own. You can see the picture on the left when they're illuminating the scrotum with a light. That scrotum that's filled with fluid illuminates red. You can see the picture on the top. Both sides are involved, but it doesn't have to have both sides involved. You can have one side or the other. Herniation of the scrotum is possible with HYDROCELE, as well as torsion. So it's important to monitor for pain as well. Cryptorchidism is when the testes fail to descend into the scrotum. Unilateral is more common than bilateral. The testes are warmer when they're in the abdomen, so the sperm cells will deteriorate, especially if both testes are involved. Sterility can result. This is often accompanied by an inguinal hernia, and testicular torsion can occur with cryptorchidism as well. So monitor for scrotal pain, or if on the undescended side, acute onset of lower abdominal pain. The testes will continue to secrete hormones directly into the bloodstream, so secondary sex characteristics are not affected even if the testicle does not descend. As far as treatment goes, we'll initially try hormonal management before surgery. So HCG, or human chorionic gonadotropin, can be used to try to get the testes to descend. Orchiopexy is the surgery that improves the condition, and it will improve fertility rate to get it descended as fast as possible. But overall, the fertility rate remains reduced among patients who have had cryptorchidism. There's also an increased risk of testicular tumors as the child reaches adulthood. After surgery, scrotal support is important. You can elevate on ice as well. Prevent contamination of the suture line with feces, because these kids are usually still in diapers. And once the child gets older, it's important to teach testicular self-examinations because of that increased risk of testicular tumors. Psychological and emotional support, especially for like the toddler or the school-age child, is important because surgery on their private parts can be very embarrassing. And it's important to reassure the child that the penis is not going to be affected or cut off. And lastly, let's discuss some menstrual disorders. So dysmenorrhea is painful menses or cramps, and primary dysmenorrhea usually starts within the first couple cycles of menses. It's lasts through at least the early to mid-20s. It's a spasmodic kind of cramping in nature, and the discomfort is usually in the lower abdomen, the lower back, and down the legs. It's the most common in nulliparas, so people who've never been pregnant. And we treat this with like heat packs, rest, ibuprofen, and many doctors recommend laying supine with the legs elevated to decrease the pain. Sometimes oral contraceptives or some sort of hormonal birth control will help as well. Amenorrhea is the absence of menstruation, and it's normal before menarche, so normal before the onset of menstruation. It's normal during pregnancy and after menopause. It is abnormal when it occurs from like problems with hormones or weight loss or severe eating disorders. Premenstrual syndrome or PMS is associated with abnormal serotonin response to normal changes in the estrogen levels during the menstrual cycle and can be accompanied with significant mood swings. And Mittelschmerz is ovulation pain, and this is experienced by women in the middle of their cycle, usually about 14 days after the onset of their last period. The pain is harmless, and it usually will cycle from one side to the other, or maybe skip a month if they only experience it on one side. That can be treated also with NSAIDs like ibuprofen and heat and rest. So to summarize, when you are thinking about how to take care of the child with a genitourinary condition, always look for immediate life threats or safety concerns. Is there anything that is an immediate risk for life or limb? And that includes, safety threats to you as well as the patient or other visitors. And then manage the airway, breathe or ventilate for the patient, provide oxygen, control any obvious bleeding, as well as, check circulation, IV therapy, fluid therapy. Assess the disability, so the neurologic or mental status, expose and examine the skin, treat any skin conditions, and then psychosocial support and teaching. Thanks for watching.